to our last speaker, Dr. Mickey Katzir. So Dr. Katzir is an assistant professor of neurosurgery at our center, also joined us not too long ago. He is duly fellowship trained in minimum invasive and complex spine surgery and oncological spine surgery. Today, he's going to present some new technology in oncological spine surgery with some work we did together. So with that, have Dr. Katzir start.
Just a second. Let me try and share. All right. Can you see my screen?
Yes, we can.
All right. So thank you for the introduction, Kevin. And hello to the attendees of this great meeting. And thank you for the organizers organizing this symposium, even in these unprecedented times. And thank you as well for having me present here for the second time. We are going to talk about new technologies, dosimetric accuracy, and complication avoidance in the management of spinal tumors. I'd like to also thank my resident, Ahmed Mansi, for helping me prepare this presentation. These are my disclosures. The topics of new technologies and complication avoidance will be discussed specifically regarding radiation therapy for spinal metastatic disease. I will not talk about generally what complications can arise in oncological spine surgery and generally what new technologies I use. So some general statements for the attendees that don't utilize this on an everyday basis. Advancements in radiotherapy has led to increased interest in safe delivery of ablative doses of radiation with stereotactic body radiotherapy. There's an increasing use of SBRT for the treatment of spine tumors because of the reduced side effect profile, ability to target multiple metastatic lesions, ability to deliver higher doses of radiation to target areas accurately, and most importantly, the ability to have better local tumor control compared to conventional radiotherapy. Of course, there are indications for conventional radiotherapy, which we all know as widely metastatic disease, biologic pain control, radiosensitive tumors as lymphoma or multiple myeloma. Several studies have demonstrated delivery of high biological effective doses of radiotherapy with SBRT precisely to the spine. It yields prolonged local control along with pain relief. This is a meta-analysis of recent papers about SRS showing 88% of symptom control and 87% of local tumor control. I took part in this clinical research study that was published several months ago in the Red Journal, where we specifically analyzed local control, progression-free survival, overall survival, and toxicity after postoperative SBRT. The most common regimen was 27 gray in 3 fractions. Most of the patients underwent vertebrectomy in the thoracic spine, were embolized preoperatively. Mostly more than 2 levels were involved, and the RT extent was circumferential. We saw that performing SRS less than 40 days after surgery improved the 1-year local control from 75 to 95%, and that preoperative embolization improved local control. RCC had the best local control compared to other histopathologies. Post-SRS compression fracture is a known complication, and this is a complication avoidance talk as well, so we can perform prophylactic vertebroplasties on some occasions, although I'm not a big fan of these. There are some factors shown to contribute to developing fractures, or like osteolytic tumors, significant involvement of the vertebral body, and press or ulcerative fracture, and to some degree the dose per fraction. The most, of course, the most common, the most fearful complication is myelopathy. due to radiation treatment, but another complication that we would really like to avoid or at least minimize its risk is the skin injury, which could be in the spectrum of very mild injury to deep ulceration of the skin and the underlying soft tissues. That's why so just an FYI, I'm going to have some graphic pictures in this in this lecture, in this talk, so be warned. So that's why I partnered up with plastic surgery here, and they are specifically Dr. Figi, and they are closing these wounds with the help of muscle flaps to add more layers on the hardware. There's less tension on the skin, and even if the skin dehisces due to any reason, there are still layers covering the hardware. These are intraoperative images of a patient that did surgery on. He had a renal cell carcinoma with a static lesion to the spine and to the chest wall, involving a rib causing spinal cord compression, which have undergone surgery to resect the tumor. After the resection is complete, we were left with a big defect in the chest wall. Here's where my partner, Dr. Figi from plastic surgery, came in and performed this muscle flap coverage of the hardware and the chest wall. This is the preoperative image, which shows the mass in the thoracic spine and the chest wall mass, which is originating on the rib and invading the spinal canal, causing cord compression. We might ask ourselves, and me, why do we need to resect the chest wall mass and not just decompress the cord? Well, it's a great question, and it's because this is a renal cell carcinoma met, which is known to be a notoriously hypervascular and tumor. And because of that, a very bloody tumor while resecting it. We would not be able to just decompress the cord because the rest of the mass will keep on bleeding until it is completely resected. Which leads me to another complication avoidance strategy specific for hypervascular tumors. This is for the same patient, preoperative embolization. It is a very important procedure to perform prior to surgery in this patient population. So this is the same patient we saw before. On the left, you can see the vascularity of the tumor before the embolization procedure, and on the right image, we can see almost no tumor blush after the embolization procedure, and you can see actually the coils in the major vessels on the right image. And this is the final construct with the screws, rods, two-level corpectomy, and the cement in the front where the vertebrae were. One more example to demonstrate our close working relationship before we move on to other topics of the talk. So to demonstrate our close working relationship with plastic surgery and with the primary goal of lowering the rate of wound complications after surgery and making sure the patient is ready for radiation therapy, making sure the wound is strong enough and can withstand radiation. So this is a patient I recently performed surgery on. The patient had a biopsy-proven chordoma in the sacrum on the upper panels. You can see the preoperative MRI on the left with axial and sagittal images. On the CT, and on the right, you can see the CT scan showing the extensive presacral mass compressing the rectum and the sacral nerves. On the lower panels, you can see the 3D reconstructions. On the left, AP view, and next to it is the sagittal view, and the two images on the right demonstrates the proximity of the tumor to the major vasculature, the arteries, the veins, and these needs to be controlled and respected during the surgery in order to avoid a major complication that might happen in this type of surgeries in this area of our bodies. So here we saw some graphic images. So these are really intraoperative images, and the goal of this showing these images is just to show how to avoid complications in this type of population. So this image shows the skin incision for the surgery, where you can see that the biopsy site is ellipsed out, and it will be resected and blocked with the tumor itself in order to reduce the risk of recurrence of the tumor and in the skin biopsy site itself. This is a very important in primary bone tumors and the major tool in avoiding a complication, which is an avoidable tumor recurrence at the biopsy site. Another tool to use during the surgery in order to avoid the complication and to achieve an en bloc resection with negative margins is intraoperative navigation. with the help of the intraoperative navigation, I can plan my osteotomy site in the sacrum accurately, and by that avoid excessive use of fluoroscopy, and most importantly, avoiding entering the tumor, which is presacral, but I'm approaching it from the back. And by that, again, achieving an en bloc resection. And you can see the blue pointer here with the yellow extension on it, predicting the line of the sacral cut, which is above the tumor. This is the pointer that we use for the navigation, this blue one. And in order to achieve a complete resection, the thecal sac, the dura, must be ligated, which is seen here, ligated with sutures on the left, and on the right, we can see the thecal sac that has been cut. And this is a zoomed-in image which shows the pre-cut thecal sac on the left and the post-cut thecal sac on the right. This is the cut on the thecal sac. And after that, we can resect the tumor in an en bloc fashion in one piece, and this which contains the skin, as we talked before, on the left here, muscles in the middle, and the sacrum itself with the tumor inside it here, and this is the skin, and this is the ventral part of the tumor, all resected in one piece. And now for the complication avoidance. This is the image which shows the resection cavity with the retroperitoneal space bulging from the front. This is where, again, plastic surgery has performed extensive reconstruction with muscle flaps and a metal mesh in order to avoid wound complication. And the post-operative MRI shows the resected sacrum here with the chordoma. And very interestingly, you can see the metal mesh implanted by the plastic surgeons. A major problem arises when we need to plan the radiation for an instrumented spine. It is critical not to violate the thecal sac, the spinal cord, with radiation. Titanium instrumentation makes follow-up imaging and radiation planning difficult due to the significant artifacts. Look at the significant amount of artifact caused by the titanium screw on the CT scan on the left side of the image compared to the almost invisible screw on the right side. On the MRI, we can see the carbon fiber instrumented spine with minimal artifact. In my practice here, I utilize carbon fiber instrumentation wherever it is possible. It is not always possible due to the limiting factors made by the screw size available and the length of rods available, made from carbon fiber, of course. But these are just technical issues which will be resolved soon. In addition to improved monitoring due to better visualization of disease progression and recurrence after the instrumentation, would the dose delivery and accuracy will be improved with carbon fiber instrumentation? So this question led our research team to plan a unique experiment, which is first of a kind. We wanted to investigate the dosimetric accuracy of carbon fiber instrumentation compared to the traditional titanium instrumentation in the thoracic spine, which is the most commonplace in the spine for metastatic disease. We wanted to simulate as accurately as possible the dosimetric calculations and to simulate the real-life scenario. In order to do that, we used a non-fixed human cadaver. Dr. Zhang on the left and Xu is on the right, and I think that the guy in the middle looks a little bit like me. A couple of words about the facility we performed this cadaveric study. It would not be possible to perform it without the support from the IXL facility and team here at the University of Nebraska Medical Center. And IXL stands for the Interprofessional Experiential Center for Enduring Learning, and this is the facility. To date, there have been no cadaveric studies looking at carbon fiber versus titanium instrumentation of the spine and the dose delivery accuracy with SBRT. So we started performing the surgery on the cadaver by the thoracic spine was exposed, and at two distinct thoracic segments, I performed the laminectomies. I followed the laminectomies with inserting the screws and the rods with the help of fluoroscopy. One segment contained carbon fiber instrumentation and the other segment contained titanium instrumentation. Here we can see the insertion of the screws with the help of fluoroscopy. This is in the midst of the surgery. Here is Kevin, Shu, and our X-ray tech, Carly. This is a zoomed in image showing the carbon fiber screws at the top. At the center, I'm retracting the thecal sac, dura, and implanted OSLD chip in the epidural space. And this image shows the final construct for carbon fiber screws with two rods on the right side of the image and the titanium instrumentation on the left side. You can see the chips in the epidural space. We then covered everything with gel, so there will be no air at the cavity and no air artifacts. And these are the X-rays that are showing the radiolucent carbon fiber instrumentation with the OSLD chips. Here are the carbon fiber instrumentation. You cannot see them. Maybe you can see the screw here and here, here and here, but it's really radiolucent. The chips are here, these dots. This is a very obvious titanium screw and rod with the chips here. And this is the sagittal side view. This is an AP view. We used the VMAT planning for the of thoracic SBRT, and the OSLD chips were placed in the epidural space, 3 chips per vertebral body level, 6 chips for each instrumentation, carbon fiber or titanium, and 600 centigrade in 1 fraction was prescribed to the T-spine vertebral bodies. You can see the dose volume histogram on the right. The yellow is in the spinal cord, and it shows it doesn't receive most of the dose. The thick pink lines are the readings from the same level chips, and the thin lines are from adjacent chips. You can see not all the same level chips receive the same dose. Of course, it depends on the proximity of them to the high isodose area. This is how we evaluate the treatment planning, and we can measure the mean dose in each chip. This histogram and plan is for the chips placed near the carbon fiber screws. And this histogram and plan is for the OSLD chips placed near the carbon fiber screws, but above the rod, the carbon fiber rod here, shown here. Here, sorry. And this histogram and plan is for the OSLD chips placed between, far away from the titanium screws. These are the screws here. Okay, and this histogram and plan is for the OSLD chips placed between, far from the titanium screws with titanium rod. That's the rod. And this histogram and plan is for the OSLD chips placed near the titanium screws, seen here on the bottom right. So this table represents the mean dose each chip received versus the calculated dose it should have received according to the planning software, and the difference in percentage between them, the calculated and the measured dose. Measured is what we measured on the chip. Before we go on, there is one chip that is an offliner because it failed. We still don't know why, but one of them didn't work. So for the carbon fiber chips near the screws, here, where the scatter should be high, we can see our accuracy is very good. The difference between measured and calculated dose is very small, 1.6. If we average the numbers, these numbers out, and use absolute numbers and not percentages, we can get the table here on the right. The p-value is not significant for either the carbon fiber group or titanium group. We have one offliner that I just told you before, and it is probably having a lot of effect on the p-values. But there is a significant p-value when we compare the carbon fiber screw group near the screw. So this group to the titanium group near the screws, this group. So the p-value between them, it is significant, is 0.0057, which means that if we have a titanium screw, the area around it has a much higher uncertainty and unreliability. Near the screw means about a centimeter. So more accurate dosimetry and radiotherapy delivery with carbon fiber screws compared to traditional titanium screws may have implications on optimal radiation delivery, as well as complication avoidance due to reduced scatter, thus lower variability in radiation delivery. It means that at a certain level of the spine, a certain level might receive less or more radiation than it actually needs. So either we are over-treating that level or under-treating that level. And that could be, that could have, of course, complications for the patient. Are we not treating him enough, or is he getting more radiation than needed? This was only one cadaver experiment, and of course we will have to perform more research in this field with more cadavers and other segments of the spine, cervical, lumbar, sacral, in order to validate our results and see whether they're really true or not. This is some more pictures from the experiment, and my time is up. Thank you so much for being here. Let me stop sharing.
Well, thank you very much, Mickey, Dr. Katzir, for your very excellent talk. And I'm glad to see the study we did pan out with some interesting result. So we are a little late than scheduled.